Hi everyone, it's your friend Doris, TheCoder, back with another video, and in this video we are going to do target practice. This is kind of a part 2. If you haven't seen it already, check the channel. You're looking for the video that says Congenital Cath Coding 2022. This is a part 2 to that. So a lot of those terms that I discussed in that video, the flow of anatomy and all of that terminology, I'm going to apply for you here in this report. So we'll start this out with just kind of going through what the anatomy is. And if you're new to my channel, welcome. If you are coming back, well, come on back. Thank you for coming back. Remember, like it if you do, share it, subscribe it. And I love the comments. I don't get a lot of them, but I love the comments. Tell me what you thought about the video. Did it simplify this for you? Was it helpful for you? Did it make it even more confusing for you than it was before, which wasn't my goal? Let me know. So this is your normal heart. And in case you don't have an image of that, I just wanted to give you a quick snapshot of what it looks like. So blood comes into our venous structures. It goes into the right atria, right ventricle, pulmonary circulation, through the capillaries into the pulmonary vein. The pulmonary veins are apart. It's hard to see on this image, but you have 2 holes here and 2 holes on the other side of the left atria. This is why your pulmonary veins are left heart structures and your pulmonary arteries are right heart structures. So from the pulmonary vein into the left atrium, through the mitral valve, into the left ventricle where it's pushed out, through the aortic valve to the entire aorta where it's filled. This is how blood should move through the heart naturally. But because of pathology, sometimes it doesn't. So we're going to look at a report for a patient who has aberrant anatomy. Now, this patient has hypoplastic left heart syndrome, right? So to just get a visual, and I think this is post-surgically, right? So the Norwood procedure that they've had here is a single ventricle disorder, and this depicted as a single ventricle disorder, but a lot of single ventricle disorders aren't truly single ventricle disorders, meaning it's not that the patient doesn't have a left ventricle. It's just they don't have an adequately sized, they have an underdeveloped left ventricle. So you might have a person that has something that looks like this, right? So see this tiny little thing right here? That's the left ventricle. Well, if I'm carrying this much blood and I'm pushing this much to the lungs, this ventricle needs to be at least the same size of this because the same amount of volume is going to come back. So this is a patient that doesn't have a true single ventricle disease, but it is referred to as a single ventricle disease in the degree of functionality and efficiency. So that's why HLHS is what they call a single ventricle disease. You might have a patient who literally just has a single ventricle where there's no walls. It's just one ventricle, right? There's no walls. That's another type of single ventricle disease. But this is the one that's in the report, HLHS. And HLHS could be any of the left-sided circulation structures. Left-sided structures like aorta, mitral valve, aortic valve, left ventricle, etc. Even pulmonary vein issues, but you've got a unique code for pulmonary vein. Those are all left-sided circulation. So this patient has had a Norwood procedure stage 1. A bilateral Glenn is what the doctor indicated, so that bidirectional Glenn. The extracardiac Fontan. Now, Glens and Fontans are alternate names for cavopulmonary anastomoses. That is, when we surgically directly connect the superior vena cava and or the inferior vena cava directly to the pulmonary artery. When we do that, blood does not have to go into the heart to make its way to the lung because we've tapped directly into the lungs. So this patient has had a Norwood where we've made the hypoplastic underdeveloped aorta a lot larger. We can't do anything about the absent ventricle or the hypoplastic left ventricle, but we make the aorta a lot larger. We blow a really big hole in the intraatrial septum, which is not depicted very well here, but they make a really big hole. That's going to allow the blood that comes into the left atria to mix with the blood in the right atria, right? So we're going to pull that blood from there, right? And then the physician is going to surgically anastomose, that is, connect 2 things surgically that don't naturally connect or touch. That's anastomosis. You heard that term in my cabbage video, so you can check that out if you code cabbages. They surgically anastomose the new aorta, you'll have them say neo aorta, the new aorta, to the right ventricle. And now the right ventricle, and this is where you see the term systemic or subaortic. The right ventricle is now directly connected to the aorta. That's not what happens in normal anatomy. It's surgically altered. And this is why our guidelines that I covered in the first video are going to be helpful for you. So this is what this patient's anatomy looks like. So when we go back to our report, I've highlighted for you, and you can pause this and zoom so you can see all that. You can pause this video so you can see everything here and read the report on your own. But this patient has hypoplastic left heart syndrome. And typically HLHS is treated stage, meaning they don't do all the procedures at one time. And even the procedures that they do are palliation, meaning they don't cure it. It holds them over until they can get the patient a new heart, because we just don't have a surplus of hearts sitting around. So this patient's had a Norwood, which is stage 1, where they made that big hole in the aorta, as I showed you that picture of. They've had a Glenn. Glenn pertains to a superior venocaval pulmonary anastomosis. That's when we take the blood, the large vessel that is draining blood from the upper body, and attach it to the pulmonary arteries. The inferior vena cava is still at that point going directly into the atrium. Then they did the extracardiac fontan. That took the bottom part that allowed this, right? So this is a Glenn, and this is a fontan. Fontan typically refers to your inferior vena cava being directly anastomosed to your pulmonary artery, right? So they've had all of those procedures, and that becomes important because what just happened after the Norwood is our right ventricle is now pumping directly to the aorta. And our coding guidelines tell us that the right ventricle, the subaortic or systemic ventricle is coded as a left heart cath. Whether irrespective of the position, surgically altered, it doesn't matter. If it's pumping to the entire body, it is the systemic ventricle. So when we go back to this report, if we're not careful, and I'll just call them out, we'll see left-sided circulation, right-sided circulation, right. All of these are right. And if you're not careful, when you see right ventricular end diastolic pressure, right ventricle, you would say, oh, this is a right heart cath, Doris. You could make a mistake there because that's right. And if I did not acknowledge, the pathology of the hypoplastic left heart syndrome and the surgical procedures that the patient did, I would have coded this as a right-hearted cath. Factoring the abnormal connections of the Glenn and the extracardiac, I would have coded it 93594. However, when I apply my guidelines, the surgical terminology, the pathophysiology, and I look at my physician's path, this is actually a right and left heart cath. Now, one of the things I told you in the video is one prompt for you outside of understanding like the Norwood, right? And understanding some of the procedures that you see, the pathology, how they often treat it. It's important to note that providers that are interventional cardiologists, the ones that work in the cath lab cardiologists, most of them don't do the kind of procedures you have to factor. So if you're not terribly comfortable with them, the visuals will help you. Don't be too hard on yourself. Because again, you put the cath lab, they don't do those procedures, but someone else has done those procedures, and it alters what you're going to see in your report for your cath lab data. So that's why I recommend you're aware of the terminology. Third thing I said, be on the lookout for your catheterization that kind of seems to like double dutch, right? It's going here and then here and here and here, just all over the place. They don't manipulate a catheter throughout the heart like that. This is why even in the coding guidelines before, you would see like 2 punctures when they were trying to do a left atria and a left ventricle. And you think, well, why can't you just kind of do that directly? Because how they would puncture and access is a little different. So you would see 2 punctures anyway, even if you were doing different chambers on the left side of the heart or left heart structures. So my provider, this looked kind of weird, and I didn't typically see it out of order like that. They did IVC, they did the pulmonary capillary wedge, then they went right ventricle. That didn't totally throw me. But then the provider went down, and again, I've got a fontan. So if I finish my Fontan, then wait a minute, where is the blood? Where's the right ventricular blood going? That's another thing that should prompt you. But then she told me the systemic ventricle, no pressure gradient from the systemic ventricle to the descending aorta. You won't typically see subaortic, systemic, subpulmonic, morphologic. Those are terms you typically don't see unless there's aberrant anatomy or something has kind of happened. And of course, if there's aberrant anatomy, they'll do the shunts. They only do the shunts if the patient has aberrant anatomy. But when we look at the catheter course, which because of the guideline, I won't rant over, but I still don't have an answer, and it's really a little frustrating to me about the guideline that's in the non-congenital Cath codes, but it speaks to a condition that's uniquely and exclusively congenital. It says something about Cath path. So I've reached out to my doctors and I'm like, listen, this is a gray area now, but I need you to document your catheterization path. I have a couple providers that often do it, some not so much, others, that always do it. So this was kind of a thing that helped ping me, and I was happy our provider supported us here. We went from right femoral artery, so we're coming from the bottom, right femoral artery, descending aorta, ascending aorta, and then all of a sudden we're in the right ventricle. So we go from left-sided circulation to right-sided circulation via arterial stick, which again, if patients have shunts and things, that's not a challenge. But seeing them do this made me go back and say, wait. What is going on up here? The Norwood told me why they did that, because the patient had already had stage 1 HLHS treatment, which was the Norwood procedure. Now, if you don't know what a Norwood is, you'd have to research what a Norwood is. It would make sense. But that's why my catheter path went there, because now my right ventricle is the systemic ventricle. It now has the responsibility of not pushing blood to the pulmonary arteries, because the Fontan is doing that. It's going to push blood to the aorta and to the aorta to the rest of the body. So now the right ventricle has been surgically fashioned to function like a left ventricle. So this CPT code, don't just ignore your abbreviations. Don't lean too heavily on your abbreviations. Is not a right heart cath. It is a right and left heart cath with abnormal connections. CPT code 93597. I hope that made that easier. Cath coding can be really complex, and the more you understand the terminology and the anatomy and the pathophysiology, it gets to be a lot easier. But until you get to that point, you might want to pull your hair out, eat some cheesecake, or drink something. I hopefully alleviated some of that for you. So I'm your friend Doris, TheCoder. Again, if you like it, give me a thumbs up. Give me a comment if there's something you want to hear about, or tell me what you thought about the video. Did it make it easier for you? Did it make it worse? Are you just as confused as you were when you came in? Again, don't look at this video before you look at the other video on congenital catheterizations, and come back to this one if you need to see if you can navigate better through your report. If you think this video could be helpful to someone, share it with them. Share it and subscribe so you are notified when I post, and you can be in the know. So again, I'm your friend Doris, TheCoder, signing out with another video, and until then, I'll see you then.